I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Hello, my loves, and welcome back to the Love and Science podcast. I have a distinguished guest today. He's a friend, he's a colleague, and we're going to talk about something today that we don't get to talk about, which is men's sexual health in the fertility journey. And so, Dr. Kuan, thank you so much for joining us today.
Thank you. It's great to be here.
Yes, I'm so glad to be here with you. And, I think that we should really introduce you because that's important. You have a lot of accolades. You are a board-certified urologist with more than 20 years of experience in men's sexual health. You're the founder and CEO of Sexual Medicine for Men, which is a physician-led direct care practice in Seattle. And since 2022, you've served as the medical director of the Seattle Sperm Bank, which, I have my clinician hat and my coach hat, and man, do I do a lot of counseling about sperm donor selection. So I'd love to get into some of that. And also, you have a newsletter, which is amazing, which is called Sex After Retirement. And we'll get into it. I think there's a lot of parallels between sex during the fertility journey and sex after retirement. And I would say just from a gestalt that you have a very candid perspective. And I know this not just professionally, but personally from knowing you, that you take this very passionate, very practical perspective to conversations about erections, testosterone, prostate health, sexual function, and the various issues men struggle to talk about. And like I said, it's sensitive. And so I'm really, really grateful that we can have this conversation today.
Thank you for having me. I appreciate the work that you're doing for colleagues, right?
Yeah.
Colleagues who are in the midst of running practices, taking care of patients, but also looking to family plan. And so I want to be of service to you and to your listeners today and their partners. Because I think family planning, we need to think of it as a team sport.
Yeah, absolutely. I was thinking this story just came into my mind. I was a fellow, and I remember taking care of this dual physician couple, and I was doing the egg retrieval on the female partner that day. And as is very typical, the male partner needed to produce a sperm sample that same day so we could do the fertilization that afternoon. So I remember I was sitting in my office and I had a window there. You don't always have a window, but I did that day. And I looked outside and I saw the male partner in the parking lot, literally shaking his fists at the universe and cursing God. And I'm not being dramatic. He was trying to produce a sperm sample. He was unable to. He had not anticipated not being able to produce a sperm sample that day. And, male physician, high achieving, wanted to do well by his wife in the process. And I truly remember him shaking his fists, getting down on his knees and just so broken at his inability to produce sperm that day. And, I remember I went outside. I think I still had my scrubs on. I was like, hey, and I knew him. I was like, hey, how can I help? And, I'm so sorry that this has been so stressful and let's see what we can do. And, we provided some Viagra for him. He went to the pharmacy. That actually did the trick, produced the sperm. And they were so apologetic after the fact. They're like, I'm so sorry we caused you so much grief. I'm like, no, I'm so sorry. This was so awkward and stressful for you. And so maybe that's a good place to dive in, is just to talk about how awkward it can be to have these conversations, to ask men to produce sperm on command, and also the shame that can come when that's not happening.
Yeah, I think that is a more common story than that guy felt in the moment.
Yeah.
And I think that story highlights so many of the aspects of the partner, the male partner side of this fertility journey. I think just from a statistical point of view, a performance alone point of view, almost 10% of men aren't able to produce the sample on the day of egg retrieval or IUI.
Wow.
And so simply normalizing that, and just thinking about that. And it comes down to a performance anxiety. I think it comes down to the environment. It comes down to the weight and the gravity of what is happening on that day.
Mm-hmm.
And the reality is when there's a lot of adrenaline in our system, physiologically, things like erections don't happen. When we're worried, when the house is burning down, we're not feeling that in the mood. And so just the stress and the anxiousness can affect erections and the orgasm and the ejaculation part.
Mm-hmm.
And I think, we might talk about this a little bit more, but just even on its own, almost a third of men experience new onset erectile dysfunction during fertility treatment. And then put on top of that the need to perform in your office,
Mm-hmm.
and to provide the sample into a cup. And there's kind of this burden of it's just a sample into the cup. And then there's the failure that I couldn't provide that sample, which is so simple. And so the whole process and the
Yeah,
data show is really an emasculating procedure. It is a
totally.
real threat to men's identity, even when there's not a male factor in the infertility puzzle. The threat to identity, the need to have sexual activity on the schedule, the need to ejaculate
Mm-hmm.
into the cup,
Yep.
being told that their part is fine. Maybe even, let's say this guy was able to produce a sample. It's like, great, we got the sample. Meanwhile, there's the disconnect that they're then observing, their partner, their wife, going
Yep.
through many invasive treatments and much more involved therapy. And so there is a real kind of disconnect, and men feel lost in this.
Yeah.
And
Yeah.
so, and then high performing men,
Yeah.
people who are in their quote unquote prime that should be able to perform, can't. And I think one of the things that I was thinking about before this, and your story, as you said, he was in the car, reminded me of just some feedback of some patients who are part of their own fertility journey, who go to the fertility clinics and they say, this is designed for women. The atmosphere feels like it's for families and women. And then I'm supposed to go down the hallway in this place where it's all branded for women.
Yep.
And that was a disconnect as well. And so I think I'm not asking, you and your colleagues, but I'm just to change, your
Yeah.
office and things like that. But it's more just to share to your listeners that this whole experience, I don't want to say asymmetrically, but is designed, and by design, it should be in many ways, for the female experience. And
Mm-hmm.
I don't want to offend anyone by that, but it's sort of the reality and the experience of what men, are reporting in the data and just anecdotally to us.
Yeah, no, I think that's a great point. And even if you have the room that's like tucked off in the corner of the clinic, like our room right now, we just had discussions about it at the University of Vermont because it's literally the hallway that's the throughway between where the patient area is and where our IVF suite is. And it's this actually has a fun fact. As a med student, I actually wandered in there thinking it was the bathroom. And then people were like,
Right.
no, that's the sperm collection area, Erica. Like I just like, it's like this very trafficked area. And I feel so badly. I mean, thankfully with COVID now we have the ability for some men to produce sperm in the comfort of their own homes, which is, I think, an
Mm-hmm.
improvement. But, there's just like the noise and what kind of materials do you provide and what's the Wi-Fi connection and all those things like that may not even hit people's radar. Sometimes materials
Mm-hmm.
are outdated and we have to talk about that too. And so it's just a very artificial process that I think you hit it. Like it really hits the core identity of the person who may be feeling helpless to help in this process where things maybe aren't working or they're seeing their wives undergo all these procedures. I find that even getting the first sperm sample in the first place is a challenge. And I've always wondered about that because I'm thinking about it. Okay, this is thinking about, that it's not necessarily a painful experience, but it's an awkward experience. Like sometimes the female will come in and her whole thing is done. And I'm like, okay, we're just waiting on the semen analysis. And, but I think it's not a physical barrier. I actually think it's an emotional barrier because there was those questions. What if I am part of this equation? What if my sperm, aren't good? I think there's something very deeply like biological and evolutionary that comes up in those moments. What do you think about that? Do you see that?
I do.
Yeah.
And I think that just, there's a couple things, and the word that came to my mind as you were describing the collection room, and then you were describing couples coming where the female workup is near complete, is in both of those scenarios, the word afterthought came
Mm-hmm.
up.
Yeah.
And that designing or the collection room is an afterthought to design of the whole clinic.
Yes.
And the workup of the male is an afterthought. And this is not to say that the workup, historically, I think, and probably incorrectly, we have placed the burden of fertility on the female partner.
Yes.
Right? It must be the egg. It must be her body. It must be that she is doing something wrong.
Yep.
But I think more recent data coming out about the paternal gamete, the sperm donor, the father, is suggesting that it's way more than just the egg. We used to think the egg was this mighty thing, and the sperm just kind of knocked on the door and was like a USB drive, and here's the information, here's the DNA. I can't get into the deep part of the science, but one way that it was explained to me is that, there's the USB, the information part, but the sperm actually has a whole operating system as well. That the sperm actually primes the immune system and primes for the first cell division. And so a healthy sperm is as important. And why I bring this up is timing and the workup. It's not as much of an afterthought, I think, as we used to call it.
Definitely.
And that the male partner should be evaluated parallel and alongside the female partner. And the reason I think for this, as someone who has seen men for male factor evaluation, if I find something on that early semen analysis, it may actually avoid an extensive evaluation on the female partner that they maybe didn't need right now.
Yeah.
And I think we're a little bit trapped by our guidelines that say we should wait, 6 or 12 months before we even initiate that investigation. A semen analysis, we've just talked about how challenging and awkward it can be, is not a hysterosalpingogram,
right?
Is not transvaginal ultrasound, is not these very invasive tests. It's the out-of-pocket cost and the awkwardness.
Yep.
But preparing and doing that journey parallel, if there is male factor there, might actually inform better the female evaluation, in my opinion. And so I think the message is that male factor evaluation, male factor fertility or infertility shouldn't be an afterthought, sort of in how we access the clinic, in how we access the evaluation, and then proceed through the care.
I think that's absolutely right. And I guess my question then is, how do we make it less awkward? I think certainly home collection does make it less awkward. I mean, as the director of a major sperm bank, what are your thoughts about like helping to reduce that and making male evaluation not an afterthought, but more central, more centered?
Well, I think it's just we have to normalize the role of the male factor in the family planning, right? That I even as a urologist who I didn't have a practice that was just infertility. Infertility was a smaller part of my practice than sexual dysfunction. But it often happens elsewhere. The male factor happens in our offices, and I actually think that's not a bad thing. I think in some ways, if we're talking to physician families, intended mothers or mothers who are physicians, I think it's sometimes hard to shed your white coat, even when you're home. And there is this ability to have researched, this ability to have understood, and then to have explained scientifically to their partners what they know. And sometimes I think that leaves, especially non-physician partners, male partners, maybe 3 steps behind.
Yes.
Or your sperm are the problem, you have DNA fragmentation, or your semen analysis is abnormal, is really saying, your sperm are the problem. And so scientifically, a guy can hear that, but are they emotionally ready? So where I'm going a little bit though is I know that a lot of the male factor evaluation starts in offices like yours, not necessarily with an andrologist or a urologist. And so I think I'm going to put the burden back on you.
Yes.
To say that what can you do in your practice? And I think that it can start just with inviting men into the process earlier.
Yeah.
I think that it can be about informing them. There's a study that came out of Denmark, and they talk about the 4 I's: invite, inform, involve, and then intervene with the male partner. And so I think, to your point, that sort of communication part, but I think even more practically, like I said, 35% of men have ED, new onset ED, providing a Viagra sample.
Right.
And it's not hard to prescribe. These drugs are safe. They've been there since the late 90s. They do not impact sperm. There's actually some small data that says it may increase motility and morphology. I'm not sure I would use it as an intervention for abnormal semen analysis, but I think just knowing that it is safe to use and it will not impact fertility. And it's no different than a pair of crutches if you sprain your ankle. It's like we have to get through this phase. And I think sort of being, I think another part that gets awkward for men is women historically, as we've said, own this journey in a lot of, and are asked to be the tour guides through that journey. And I think sometimes, how can we be a partner to the male partner instead of the tour guide? I think those are tough things. Those are communication things, but sort of like we talked about the mismatch between the semen analysis and invasive treatments.
Right.
The difference between, well, you're not the one having all these procedures, to, I know this is hard for both of us in different ways.
Hello, my loves. I am so excited to share this news with you. If you are a female physician navigating the fertility journey and you want a structured, evidence-based plan, I have created a free resource for you. It's called the Physician Fertility Roadmap. I have created a guide to help you optimize your chances of pregnancy and a successful outcome over the next 6 to 12 months. Check out the link in the show notes. Love you. Bye. Yes, absolutely. So I just want to reflect back a little bit what you said. So I'm hearing you say normalizing and inviting on the earlier side, which I love. I usually give the stat, about 40% of infertility is male and female factors combined. So if we're just focusing on the female, we're missing a huge part of the equation. And so, what we've started doing actually, because our wait list has gotten so long, we've started actually calling people ahead of time or sending a portal message and saying, hey, these are the tests that we like to generally see. It's not a one-size-fits-all approach, but, we're probably going to want an AMH on the woman. We're probably going to want some sort of cavity evaluation. We're probably going to want a semen analysis, if it's that type of family. And so now I love it now because I can do my new patient consultations and I have all the data in front of me. And it's more just like, if you even try to buy solar panels, they're going to want your electric bill before you do so. It's like, check, check, check. Right. And so I think about it like, okay, these are the building blocks we need to start your first consultation off on a higher level. Like that in and of itself is very normalizing because then we can have that data to begin with. And then, also this is something I'd never considered as an REI, that I could be the one to write the Viagra. I mean, I did that day when I was a fellow, but like, I would say, yes, 1 in 3 of my couples have this problem of erectile, sexual function issues that are new onset. And, I think, I normalize it, but I'm not like, oh, I could do something about it, right? Like, so I think that's something I'm going to change moving forward, is to say, okay, sure, if your semen analysis is abnormal, we can get you to see the urologist, but that might be, 2-3 months. I don't know what your wait times are in your practice, Dr. Kuan, but I think, just saying, hey, while you're trying, I can help you. Like, that feels empowering to me as an REI.
Well, and it's easy, right? Primary cares write those prescriptions every day.
Right,
and
right.
I think the one thing is, if you have someone who is using nitroglycerin, and this is not your population,
Correct.
and
right.
your listeners are very educated people who understand the contraindication to Viagra, it's that easy.
Yeah.
I think something else I brought to mind is simply normalizing it. And there's data for this. Simply normalizing that, this 35-40% of men will have new onset ED, and telling men that they are part of a group of men who experience this same thing. A third of those men will get better and not need something like Viagra just
Amazing.
by telling them this is normal. And I think the other thing that comes to mind, is we're talking about sex on demand, whether it's on the calendar because the window of time is there, or it's in the collection room and the cup is there. It's important, especially as the journey gets long, and this better than I do, that this journey can be very long.
Yep.
That there is still time made for sexual activity outside of baby making.
Yes.
Outside of the collection room, outside of that window on the calendar. Because there's also data to show that when that declines, when the intimacy that couples shared before the fertility journey declines, sexual performance worsens. And so I think that's a little bit of agency. I think that's a little bit of couples regaining, reclaiming, or just hanging on to some of their control in the relationship. When the fertility journey, as and coach, feels so out of control, so out of control for us who we've plotted and planned our whole lives, and then this happens. And so I think it's the normalization, but it's also trying to find, and I think this is easier said than done, a little piece of normal life in that journey, because that contributes to the success as well.
Absolutely. No, I'm so glad that you said that. And do you have any particular strategies that you recommend for couples to help enhance that aspect of their lives? I think that this journey can drive a wedge between people. So sometimes I see couples in the office and they're truly like facing apart from each other. That's its whole other, issue to tackle. But I think that there's so many windows. It's like, okay, you're about to have your egg retrieval, don't have sex. Or like, okay, there's all these, I think, myths really about how long people need to be abstinent before a sperm sample. And so people are ejaculating in cars. And there's just this whole, so many layers of like the rules about, and many of them are not even based on science, but like, what would you say to a couple that's like, yeah, sure, that sounds great, but like, how do we actually do that?
So the thing that I always tell men is, first and foremost, and this is where I think it's okay for the female partner to be a bit more instructive. I say, first and foremost, whatever your partner's OBGYN has said in terms of how frequently you should have intercourse during ovulation, follow that. Because if I say something different, I don't want you to get in an argument about that. Follow that person's advisor. I always say this, 2 to 4 days is ideal, but he doesn't know when 2 to 4 days, that 2 to 4 day window exists, if you don't tell him when that 2 to 4 day window exists. And so this is part of the informing and inviting them to be along with the journey. And so I often see the couples. I'm not sure, and I'd be curious what percentage of the time you see the male partner or just the female partner.
Mm.
But I will then turn to the female partner and say, I need you to let him know
Mhm.
with some range of variation when you think your next cycle will be.
Yes.
And then I look at him and I say, I need you to plan for that. I need you to understand that this is not necessarily going to happen on that exact day. Or maybe it does, right? But you understand the variability of that more, and to be prepared and to plan for it, and not just plan to take a Viagra, but plan to take a Viagra if need be, but also plan a date night. I think what
Yeah.
unfortunately happens is it's the professional couple that gets home. The other kids are now in bed. The dishes are done. It's 9:30 or 10, and it's like tap, tap, tap. We
Yep.
have to have sex tonight.
Right.
And, there's all the demands of life, but, we can make time for priorities. And if this is a priority, knowing when it might be,
Mm-hmm.
intercourse to make family doesn't have to just be mechanical. It can
Mm-hmm.
be as a result of a planned date night, even if it's just every 4 weeks, if the cycle is regular. And so planning for that, maybe even using something like Cialis instead of Viagra. Cialis, taken so let's say that female partner says, I think I think we need to have sex on Friday night. Taking a low dose of of a Cialis or even Viagra just every day.
Mm-hmm.
And just having it in the system, because we know that these drugs take at least an hour. And sometimes if both partners are tired at 10 o'clock at night, there's not an
Sure.
hour to wait for the
Yeah, that's a good
medication to
point.
absorb.
Yeah.
And so it's planning, having the prescription available before. You know what it's like when someone calls on a Friday afternoon for a refill. Having the prescription days and weeks before so that you can prepare for that. Having time on the calendar and just knowing that don't plan an evening meeting or a dinner out. Don't plan a time out of town unless you absolutely have to. And then romance still matters. I always kind of, I think there's a statistic that says 4 or 5% of couples who are undergoing fertility workup and treatment, anticipating ART, get pregnant through intercourse.
Mm-hmm.
That when sort of spontaneity and romance and fun come back into the bedroom, that the sexual response for both partners, I think we're foolish to think that sexual response is not part of what is, the juju or what is happening.
Yes.
And it is probably pheromones, it is chemistry, it's intensity of orgasm, it's the receptiveness of the female canal to,
Yes.
I'm just putting that out there also. And so it gets back to normalization as much as we can.
Yeah, no, I just did a podcast, one of my clients who had done unsuccessful IVF for a year and a half, and then she took 1 month off, and she and her husband were starting to feel like they were living a normal life again, and that's the month that she conceived and they had their daughter. So at 39, she and her husband conceived a beautiful daughter when a year and a half of IVF treatments had not worked. And it's like, why is that? There is something about that mind-body connection, and if we need IVF,
it's
we need
nervous
IVF,
system, it's hormonal, it's inflammatory, it's all of those
it's everything.
things, right?
It's everything.
It's epigenetic. If your body is so stressed out, epigenetically, what is the impact of that on our fertility? If we are telling our system, this family unit is really stressed out, does that pull back? Does that speed bump or handbrake our fertility?
Yeah.
I wouldn't be surprised if it does.
Right. Right. No, I think that's an excellent point. So I wanted to also ask your perspective, because this is something I talk a lot about with patients and couples, is people feel like they're going to be messing up the process, right? So they're just like, okay, but if we have sex at this time, and again, I know that the fertility clinic has their rules and everything, but I think that people are spending tens of thousands of dollars on this process, the emotional aspect of it. People feel they're running out of time. So, I want to normalize a little bit that like this actually might be helpful and that there's a lot of ways
The messiness.
Yeah. And like, there's
Yeah.
a lot of ways not to mess it up if you're leading like a healthy sexual life. It's just how to get from where most people are. I mean, even new pregnancy, people are so afraid to be intimate that many people haven't had sex for months because they're afraid of messing things up. And so I think also normalizing, sure, there's a few quote unquote wrong things to do, right? Like you don't want to be having vigorous sex when the ovaries are giant about to be retrieved. That can do some damage, but there's a lot, it's really hard to mess it up, really. And I think that people get these complexes which add to the stress. And then that adds a whole other layer because it's like, again, sex is bad or like we're back in Catholic school or something like that. I don't know. You know what I mean? So it's like, I think we have to think about all the rules and which rules are actually important and which ones we've imposed on ourselves because we want to be doing everything quote unquote correctly.
Well, and I think, this is sacred and precious work, right? Making family, and all the cultural stuff that goes around with that. But imagine a couple who is used to having lots of sex and we're now placing this thing on this pedestal and it's really expensive, as you say, and it's almost too precious. And I think, getting back to the question that I only partially answered, when I said the 2 to 4 days, what I would say, like from getting a semen sample, you don't want more than 5 days of male abstinence before getting the sample. Mm-hmm. And you don't want 12 hours ago to be your first ejaculation, Correct. During ovulation. And so I say 2 to 4 days. And I say, so if your wife is ovulating on a Friday, you need to ejaculate Monday, Tuesday, or Wednesday, but not after Wednesday.
Right.
And it can be that simple. And so that very sexually active couple just has to say, there is a 3 to 4 day period here where at minimum 2 day period where we can't be very sexually active. And that might normalize the rest of the month.
Right.
And then we get to be sexually active again because we're inside that window. And I think you would probably tell couples every 48 hours. I've had some people come back. Yeah.
Yeah. And I think too, like one thing I tell my patients all the time, my clients, is there's other ways to be intimate too. I think we've sort of have this like, penis and vagina intercourse as kind of like what we define as sex. And, if I'm doing an egg retrieval on somebody and they want to have intimacy in other ways, by all means, go for it, And so that's one thing that I think we can help people with is to say, think about all the ways that you like to be intimate. If we're trying to avoid, so I guess I'm talking about it from the lens of IVF, when at some point we actually do want to avoid the chance of having multiple gestation and things like that. So there are sort of guidelines around when people have intercourse or don't have intercourse around an egg retrieval, which honestly, most of my clients are already at the point of IVF. And so, but thinking about it, okay, if you and your partner really enjoy oral sex, then by all means enjoy that. You're not going to do anything harmful by having oral sex. And so I think just thinking about, or like maybe it's a night for physical touch and physical intimacy, but not sort of the, intense sexual kind that might happen at other times of the month. And so broadening what it is to be intimate, I think, is also really important. And I would imagine you do that a lot in your sexual health practice.
Well, I trained in rural Canada and I graduated in the late 90s. And so I still think that the sexual medicine training that I had was actually quite progressive. And we had this couple who were sexologists and they wrote a book. And it was called Sex is a 13-letter word. And we all received copies. And the 13-letter word is communication. And this is what you're talking about. Silence is optional here. And so is distance. Distance is optional. Distance is the default, I think, when we lose control, when we feel alienated, when we feel instructed by our partners, when we feel like we're falling more and more into our silos. And so the communication is the remedy to the silence, which is optional. And so what you're saying is it's okay for couples to say, I still want to be close and intimate and sexual with you.
Yep.
But there's this window of time. Let's talk about how we can't be sexually active, but then let's explore how we can be sexually active.
Yes.
And so
Yes.
what it's really coming down to is we have roadblocks and we place them there because they feel safe or they feel appropriate to protect this thing. But sometimes just challenging that and allowing it, as you questioned, to be messy and to
Mm-hmm.
not be perfect. There is no perfect way to do this.
Yeah. Yeah, that makes so much sense. I love that perspective, and it's something that I think I want to echo from the rooftops. Um, I'm curious, so your sexual health practice focuses a lot on sex after retirement, which we know is super important. People are living longer. We all, oh, I say we all, many of us want, healthy sexual lives well, like for the rest of our lives, right? And so I think thinking about the parallels between how you help people, which is the bulk of your practice, which is in retirement, like, can you share some pearls of that work with, sort of how that relates, well, what we can borrow in the realm of helping people have their best possible sexual lives while they're undergoing fertility treatments? If you're listening right now and finding yourself nodding along, this is usually the moment people realize that they want support that's specific to them. In addition to this podcast, I offer one-on-one fertility consults where we look at your full picture with both strategy and compassion. You can learn more in the show notes. Now, let's get back to the conversation.
Yeah, I just jotted, I think, 5 top things that kind of came to
Amazing.
my mind. I think it's normalization, as we've already talked about. Normalize that there are, 30, if we just look at erectile dysfunction, we talked about this group with new onset erectile dysfunction during fertility. A third of men in their 30s, not even in fertility treatment, have ED. 40% of men in their 40s, 50% in their 50s. That's
Wow.
the first thing. Just normalize that sexual dysfunction happens to men who are otherwise healthy, who are otherwise capable and able. And we're not talking about the 1 or 2 off nights after too much wine or a particularly stressful meeting. We're sort of talking about a pattern of dysfunction. The second thing is that this erectile dysfunction and infertility, male factor infertility, are canaries in the coal mine. For erectile dysfunction, it's the canary in the coal mine for vascular health. And I don't have to expand on what that means to your audience, but getting an erection is a vascular phenomenon physiologically. And the penile arteries are much smaller caliber than the coronary arteries. And the signs of decreased blood flow, arteriogenic erectile dysfunction, show up in the penis often years before the heart. And so erectile dysfunction as a pattern is an opportunity to be evaluated by an internist or a family doctor to make sure that he is healthy. Infertility is a precursor to male disease as well. Like
Yes.
1 to 8% of men who are evaluated with abnormal semen parameters go on to have underlying pathology, which could even be something like a testis cancer. And so understanding too that many of these men have been healthy their whole lives. For them, this may be the first opportunity for them to actually undergo a physical exam. And that's an important thing too. Semen analysis alone is not enough, but to undergo a physical exam to make sure that they are otherwise healthy. Men with infertility have higher rates. They're at higher risk of early mortality. They have higher rates of testis cancer. And so infertility, abnormal semen analysis, should prompt referral to an andrologist or a urologist for additional workup to make sure these things aren't happening.
Yeah. Bone health too, right, Dr. Kuan? Like bone health with low testosterone, bones like testosterone. I've read some data that we need to be thinking about men's bones as well.
Yeah, and I think, we may talk about testosterone replacement in a minute, and I think that where often that helps or that becomes a factor is in people who aggressively manage the estrogen levels with testosterone. But but getting back to sort of the correlates between the two, we've already talked about the communication, that it's optional, but But I think what couples in infertility experience is what a lot of couples in retirement experience is desire mismatch.
Yes. Yes.
And whatever causes that mismatch, in this case is the fertility journey. In retired couples, there's many reasons, but the low hanging fruit is the impact of menopause on female sexual function and historically in desire mismatch. And that's a difficult thing to overcome. And that's
Yeah.
something that does require communication, that may require involving, mental health professionals and couples therapy. But I will say this to the men who may be listening over their partner's, shoulder. Doing the dishes without being asked is foreplay and does help. And that there are those small things that do go a long way, and that foreplay doesn't start in the bedroom. It starts after dinner at the sink. And so being aware of that cognitive and that household burden.
Yeah.
I'm saying that because it's so obvious, but it's true.
It
And
is
so,
true. I will 100% validate that. Thank you for saying that. I tell that all the time to my people. Yeah.
yeah. And then I think the other thing is the stigma, right? We talked a little bit about how this is emasculating and how this feels like loss of control or identity. What I say to men who are hesitant, say, to use something like a Viagra or get an implant or something like that in more severe cases is using a crutch is something that you can get upset about or you can have thoughts about. But when you were 35, you used to golf without a cart and you called it golfing. And now you're 75 and you golf using a cart and you still call it golfing.
Right.
And I think the same can be said for Viagra, that, when you were 25 and you and your partner were dating and you had sex and you had an erection, you called it sex. But when you're 38 and you're having sex on the schedule and you need a Viagra to have sex, you're still having sex.
That's
And
brilliant.
so I think those are kind of the things, because, the older I get, the more I realize I'm more the same as I used to. So I would say the normalization of the dysfunction, the distance, the mismatch, the communication, the ED, and then using the tools. I think those are the parallels that happen between, aging couples and then couples pursuing fertility.
Yeah, I mean, what strikes me in that is it's something like we talked about agency before. We can have agency in each of those areas, which I think is, so much of this journey we feel out of control, right? It's like we don't know when the embryo report's going to come, or it might not be what we hoped it would be, or we're waiting on this paperwork so that the embryos can be shipped. Whatever it is, like this is largely a journey where people feel very powerless, especially female physicians and male physicians who are used to be like the drivers of the care, right? It's a very vulnerable position. And I think with each of those areas, there's actionable things we can do at each step. And I think, when we can take back our power, so much else changes for the better.
And sometimes I think it's hard. It has to be hard to step out of this I alone can fix this. We inherently can fix. And I sometimes, when I more generically treat physicians, sort of ask them, what I want you to do is allow yourself to be the patient here. I do, I'm happy to have a discussion at a high level with you, but I'm always going to have a discussion as a patient with you. And I want you to hear it and find some space to feel it as a patient, that this, we said, family planning is a team sport, not just, man and woman, but, it may even be like female physician whose partner is not medical. Let the urologist
Yes.
be the bearer of bad news. Let them break that. We always have, it's that, how much do we disclose to the family members when we operate and we found cancer, right? And then that family that says, well, I want to be the one to tell them, that always makes me uncomfortable. And I always say, let me talk to them first. And I'm happy
Sure.
if you're there, but I don't feel that you should be the bearer of this news,
Hmm.
because that's not fair to the partnership that you
Right.
have. And so I think even as physicians, we have to allow ourselves to maybe insert ourselves, to say that I want to be the person to give this news so that you don't have to, because there's already so much burden. And I'm sure you observe asymmetry in your listeners who
Yes.
are carrying the weight, and I'm sure are feeling like they are dragging their partners behind.
Yes. Yeah.
And so I recognize, the asymmetry there also.
All of that is so good. And I think, I want to listen to this again, which I obviously will, because I think that there's so many gems in here that are going to help people practically. And it's just so beautiful that you're doing this work.
And
I would
likewise to you.
Oh, thank you. I mean, it's amazing that it works too. I mean, I'm sure it's so gratifying when you see a couple that's finally getting their groove back. Or, for me, when I see a couple that has had infertility for years and like we reconnect the mind and the body, and hey, sexual health is a huge part of that. And all of a sudden they're pregnant. And it's just like, it just makes you think, okay, there are certain things we understand scientifically, certain things that we have a hunch about. We understand the nervous system's involved, like it's the HPA axis is involved. But I think that it takes the time to sit with people to understand who they are, understand their values, their goals. It's not something that I think really works in the traditional medical system, which is why I'm so glad that you're doing what you're doing with your sexual health practice. And I just know how many people benefit from your services. What I wanted to say is I wish we had time to talk about sperm bank things today and
Yeah.
testosterone replacement. I think we're at the limit of what we can talk about today, but would you come back and maybe we could have a second conversation about some of the things male factor infertility is such a giant topic anyway, but I think that I want to do those topics justice as well. And I think there's things our listeners really, really want to hear about as well.
I'll just make the one plug. TRT is bad for sperm.
Yes,
So
it's really bad.
If your
It's really
partner's
bad.
on TRT and you're trying to get pregnant, he needs to see a urologist.
Yeah.
And that there is no perfect donor. And
Yeah.
and donor choice is all, in my opinion, is all about eyes wide open. And that's what I tell. So if anyone's considering a donor right now, the first thing I say is our goal today is to get as much good information about you so that intended families can feel confident about their choice to use a sperm donor.
Yes, 100%. And so I'm genuine about that. I really would love to have you back. And I think those topics really deserve the time and attention. Where can people find you? And is there anything else you want our listeners to hear based on all the wonderful things we talked about today?
They can find me on Instagram at Dr. James Kuan, I always get a spelling, at DRJAMESKUAN.
Yep.
My newsletter is www.sexafterretirement.com. And then I do have a practice website. I only treat in the state of Washington. And if you're able to share that, it's jamesquanmd.carrd.co.
Amazing. We will put all of this information in our show notes as well so people can access it as well.
Thank you, Dr. Bove.
Thank you. Anything else you want to share today? Do you feel complete?
I feel complete, and I just feel like there's no I loved when you said it can be messy and still work, and I think it's usually messy, and then it doesn't work, and so then we build all of these protocols, but a little bit of messy gives couples a little bit of grace.
Yes.
To not feel like they are the cause for the reason that the journey isn't successful.
Yes, that's exactly it. It. Oh my goodness. Thank you so much for being on the podcast. Thank you for the work that you do. And I cannot wait to continue to collaborate with you.
I look forward to it. Thank you.
Yeah. And to my listeners, you know how much I love you. Bye. Thank you for listening to the Love and Science podcast. I'm so glad you joined us today. If you found this conversation valuable, if you could please rate, review, and share this podcast with your trusted people, it would mean so much to me. If you want more tools to help you navigate the fertility journey, please book a discovery call with me today. The link is in the show notes. Please do not let infertility have the final word. I'm here to take the burden from you so that you can achieve your goal of building your family. In gratitude, this is Dr. Erica Bove. I'm rooting for you always.